Hi everyone, welcome to the lecture on pressure injuries and diabetic ulcers. This is the second lecture in a series of 3 for your integumentary and wounds module. Please use your study worksheet to take notes, and the key terms are noted in red text in this PowerPoint. Let's get started. Objectives for this lecture include define a pressure injury, explain the pathophysiology of pressure injuries, identify different stages of pressure injuries, identify patients at risk for pressure injury development, describe nursing interventions to prevent pressure injuries, explain the etiology and pathophysiology of diabetic ulcers, identify patients at risk for diabetic ulcer development, educate patients and caregivers about caring for the diabetic feet. Pressure injuries. Pressure injury, or pressure ulcer, is a localized damage to the skin and underlying tissue that usually occurs over a bony prominence or is related to the use of a device. They're also known as ulcers, decubitus ulcers, pressure sores, bed sores. These affect 2.5 million people in the United States a year. They cause 60,000 deaths. They can be acute or chronic, most commonly in the elderly, 70 years and older. They're very expensive. They cost $9.1 to $11.6 billion a year. They negatively affect a patient's body image, decrease quality of life, and some are unavoidable due to comorbidities, disease processes, and therapeutic procedures. Factors affecting pressure injury development include aging skin, chronic illness, immobility, malnutrition, fecal and urinary incontinence, altered level of consciousness, spinal cord and brain injuries, and neuromuscular disorders. There are 4 main causes for pressure injuries. External pressure, compression of soft tissue between bony prominences and external surfaces. This prolonged pressure causes occluded blood capillaries, leading to ischemia, deficiency of blood in a particular area. This deprives tissue of nutrients, causes edema and inflammation. Microclimate, the temperature or moisture level of skin when in contact with a support surface or device. Damp skin has lower tolerance for pressure share and has a higher risk for injuries. Friction occurs when 2 surfaces rub against each other, causes abrasions, damages superficial blood vessels. This can happen when a patient is repositioned in bed, laying on wrinkled sheets, or transferred. Susceptible areas include elbows, heels, and back. Shear. Shearing occurs when one layer of tissue slides over another layer, separating skin from underlying tissue. Superficial capillaries are stretched and torn, leading to decreased circulation. This can happen when patients sitting in a chair or partially in a bed slide down when patient is pulled rather than lifted during repositioning and transfers. This diagram shows the pathophysiology of pressure injury development. It all starts off with tissue hypoxia, which is caused by pressure, which can lead to pallor. If the pressure is relieved, then reactive hyperemia occurs, hypoxia resolves, and there is no pressure injury. If the pressure persists, this will lead to tissue ischemia, which leads to an accumulation of metabolic waste. Then this leads to increased protein accumulation in the interstitial space. Capillaries leak because of increased permeability, which causes tissue to become edematous. Perfusion worsens, and a pressure ulcer is formed. The progression of pressure injuries leads to the different stages of pressure injuries. Stage 1, skin is unbroken but inflamed. Stage 2, the skin is broken to the epidermis or the dermis. Stage 3, the ulcer extends to the subcutaneous fat layer. Stage 4, ulcer extends to muscle or bone. This picture here shows the different pressure points for pressure injuries. These are the vulnerable areas that are susceptible to pressure. The stages of pressure injury include Stage 1, Localized area of intact skin with non-blanchable erythema, redness and lightly pigmented skin. Darker skin tones, skin color different from surrounding tissue. Stage 2. Partial thickness dermis loss, shallow open injury with red-pink wound bed, no slough present, or intact or open ruptured serum-filled blister. Stage 3. Full thickness tissue loss, subcutaneous fat may be visible, no bone or tendon is visible, slough may be present on some parts, and may have undermining or tunneling. Stage 4. Full thickness loss, base of injury is partially covered with yellow, tan, gray-green, brown slough, or tan, brown, black eschar. Bone or tendon is visible, and often includes undermining and tunneling. Deep tissue injury, purple maroon localized area of discoloration. Skin is intact or there is a blood-filled blister. It's firm and boggy, warmer or cooler compared to the adjacent tissue. Unstageable pressure injuries. These include full thickness loss. Slough or eschar obscures the base of the wound, and it often includes undermining or tunneling. Risk factors for pressure injuries include immobility, as seen in sedated, paralyzed, or post-surgical patients, nutrition and hydration, protein and vitamin C deficiencies and dehydration, mental status, seen in confused or comatose patients, age, chronic disease, immobility, malnutrition, physiological conditions, neurological, cardiovascular disease, hypotension. Complications include infection, osteomyelitis, sepsis, malnutrition, anemia, and death. Evaluation and management. Evaluation includes finding out the duration of the immobility, duration of hospital stay, medical conditions that cause injury, history of the injury, existing chronic diseases, physical assessment of the actual injury. Management would include minimizing pressure, keeping the area clean and aseptic, decreasing moisture, providing proper support surfaces, frequent repositioning, urinary and fecal diversions, performing wound care per orders, and managing pain. The diabetic foot ulcer. What are these? Diabetic foot ulcers are usually seen in diabetic patients. Worldwide, there are 9.1 to 26.1 million people affected by diabetic foot ulcers. They affect 15 to 25% of patients with diabetes mellitus. They increase yearly. They're very prevalent in diabetic patients 45 years or older. The highest incidence is in Latinos, Native Americans, and African Americans. The diabetic foot. Where are these diabetic ulcers found? These are usually found on the bottom of the toes, the pad of the foot, called the plantar area, the heel of the foot, and on top of the toes. Why do diabetic foot ulcers occur? They occur because of poor glycemic control, calluses, deformities, improper footwear or ill-fitting footwear, neuropathy, muscle atrophy, sensory loss, a loss of protective sensation, loss of pain and temperature sensation, autonomic, decreased sweating, oil production, abnormal blood flow, loss of skin, and temperature regulation, trauma, edema, circulation issues, including peripheral arterial disease. How are diabetic ulcers formed? Diabetic ulcers develop in two stages. Neuropathy causes callus formation, motor neuropathy causes physical deformity, and sensory neuropathy causes sensory loss, leading to ongoing trauma. Autonomic neuropathy leads to increased running of the skin. This frequent trauma leads to subcutaneous hemorrhage, then to erosion, and as a result causes a diabetic ulcer. Risk factors for diabetic ulcers include absence of sensation due to peripheral neuropathy, vascular insufficiency, structural deformities, callus formation, autonomic neuropathy, joint immobility, uncontrolled diabetes, and obesity, impaired vision, past history of ulcer or amputation, male gender, increased age, certain ethnicities such as Native Americans, poor footwear. Complications of diabetic ulcers include infection, gangrene, osteomyelitis, permanent deformity, sepsis, and amputation. Evaluation and management. Evaluation would include getting labs, such as fasting blood sugar, HbA1c, CMP, CBC, ESR, and CRP. Getting the patient's complete history, their gender, ethnicity, duration of diabetes, circulation, history of ulceration, sensory, and pressure sources. Then classifying the diabetic ulcer using a standard classification system such as the Wagner Diabetic Foot Ulcer Scale. Management would include early intervention, careful and frequent inspection, glycemic control, wound management, which includes treatment of infection and ischemia, relief pressure, debridement dressings and advanced wound care, pain control, and educate. Education of patients and caregivers is the most important responsibility of the nurse. Teach them directly, face to face. Repeat, and then repeat again. Return demonstrations. Teaching in manageable pieces. Use simple words. Reinforcement. Use visual materials. Teaching at the level and language of the patient and family. Identifying strengths and weaknesses. Sit and speak slowly. Manage background noise. Schedule teaching sessions and assess competency. Document your teaching.